Good morning, everyone. I am Pooria Koshnoodi, the fourth-year APCP resident at the University of Minnesota. And today I'm going to talk about the Rhabdomyosarcomas and current landscape of Rhabdomyosarcomas. I have nothing to disclose. Here are my objectives, which are to explain the current classification of Rhabdomyosarcomas and their clinical significance, to review modern diagnostic ancillary studies for Rhabdomyosarcomas, to discuss the new changes in subclassification of Rhabdomyosarcomas based on genotype, and to differentiate Rhabdomyosarcomas from other tumors with rhabdomyoblastic phenotypes. Rhabdomyosarcomas are the most common soft tissue sarcomas in childhood and adolescence, with annual incidence of 4 to 7 cases per 1 million of children less than 15 years of age. It is actually the third most common extracranial solid tumor of childhood after neuroblastoma and Wilms tumor. These tumors are rare after 45 years of age. However, they occur in adults, and it constitutes 2 to 5% of all adult sarcomas. There is a bimodal distribution for age for Rhabdomyosarcoma. The first peak is between 2 to 6 years, and the second peak is between 10 to 18 years. But how do we define the Rhabdomyosarcoma? Well, it is a malignant mesenchymal tumor like other sarcomas with a skeletal cell differentiation. And what does this differentiation mean? The differentiation can be observed morphologically by seeing rhabdomyoblasts with this bright eosinophilic cytoplasm, and occasionally cross-striations. If we get lucky, we can see them, or by immunohistochemical markers which can highlight them. Morphologically, rhabdomyoblast has a densely eosinophilic polygonal or spindle cell with hyperchromatic eccentric nuclei. These cells have been described as strap cells, tadpole cells, or sometimes can be called spider cell with that specific morphology. If we use electron microscopy, which was much more common years ago, we can see rhabdomyoblast with typical mixture of thick fibrils, which are myosin, and thin fibrils, or actin, with distinct Z banding in several locations. Electron microscopy was the only ancillary study to diagnose Rhabdomyosarcoma for decades until the immunohistochemistry developed later. These tumor cells typically contain generous amounts of eosinophilic cytoplasm, a feature of rhabdomyoblastic differentiation, so-called strap cells. They could be with or without cross-striations. Remember, these cells may become more prominent with chemotherapy treatment, which is called chemotherapeutic-induced cytodifferentiation. Sometimes they are called tadpole cells or rocket-shaped cells, and they have these elongated tails of cytoplasm and eccentric nucleus. This can mimic fetal myotubes at this latest stage of cellular differentiation. Occasional rhabdomyoblastic cells, particularly in embryonal cell rhabdomyosarcoma, may show centralized cytoplasm retraction and have been referred to as spider cells, in which intracellular glycogen is washed out in processing, giving a vacuolated appearance and can look similar to even lipoblasts. But it is not always easy to see the rhabdomyoblast morphologically, particularly in poorly differentiated rhabdomyosarcomas. If you look at this image, which is actually a rhabdomyosarcoma, we can see just small blue round cells, and we may get confused this with any small blue round cell tumors. Imagine that this could be small core needle biopsy, and it could be very challenging. This is where we need to apply ancillary tests, including immunohistochemistry. So that is why we absolutely need immunohistochemical stains of at least 20% of rhabdomyosarcoma for definitive diagnosis and differentials. Of course, in practice, we use immunostains much more frequently in rhabdomyosarcomas, and I would say in most of soft tissue tumors diagnosis. There is a long story of how and what immunostains have been developed since 40 to 50 years ago for rhabdomyoblast differentiation. However, for the sake of time, This paper from Dr. Murati, published in 2006, was a landmark paper, which we still use to highlight rhabdomyoblastic differentiation. They studied a big population of 1,052 cases, including 956 rhabdomyosarcomas, and proposed a trio of desmin, MyoD1, and myogenin for rhabdomyosarcomas. Muscle-specific stain in this study showed only 70% sensitivity and subsequently dropped from their panel. Their recommended panel, which is still used in most of rhabdomyosarcomas, are desmin, which is a cytoplasmic intermediate filament protein with 99% of sensitivity and 71% of specificity. Desmin should be used together with more specific DNA binding regulatory protein nuclear markers like MyoD1 and myogenin, with quite similar specificity of 90% and sensitivity of 97% in rhabdomyosarcomas. WHO classification of tumors of soft tissue and bone, the 5th edition, published a couple months ago in 2020, and classifies the rhabdomyosarcomas into 4 types. Let's start with the first group, which is the most common type and was described first. Embryonal rhabdomyosarcoma, first described in late 19th century by Dr. Berard in France. It is the most common type of rhabdomyosarcomas, constituting 60 to 70% of rhabdos. Most occur in the first decade of life, majority in children less than 5 years, and less common in adolescents. Still constitutes 20% of the adult rhabdomyosarcomas. There is a slight male predominance. Half of these cases occurs in head and neck region, and approximately half of them occur in GU tract. But they can also occur in biliary tract, retroperitoneum, or abdomen. Embryonal rhabdomyosarcomas can be associated with several symptoms, including alterations of the RAS signaling pathway, like Costello syndrome, which has HRAS mutations, neurofibromatosis type 1, Noonan syndrome, Beckwith-Wiedemann syndrome, Dicer-1 syndrome, with a predilection of embryonal rhabdomyosarcomas in cervix and bladder. We will get back to this later in this talk. And Li-Fraumeni syndrome with TP53 mutations. Grossly, these tumors are usually poorly demarcated, friable masses with a tan, white, fleshy, or rubbery cut surface. Hemorrhage or necrosis may be present. The image shows an orbital embryonal rhabdomyosarcoma with the eye globe on the left side and the tumor with a fleshy, pale tan cut surface, which had caused proptosis in this patient. Histopathologically, embryonal rhabdos can be analogous to embryonic skeletal muscle with primitive mesenchymal cells in various stages of myogenesis. It can show multiple histologic patterns, including patternless sheets of ovate to stellate cells with hyperchromatic nuclei and cytoplasm from scant and amphiphilic to more prominent and eosinophilic cells. Marbled appearance is common due to variable cellularity and loose myxoid stroma. The left panel shows marbled appearance with variable in cellularity with prevascular regions, which are more cellular than the adjacent loose myxoid zones. The right panel shows rhabdomyoblastic differentiation with dense eosinophilic cytoplasm in tumor cells and eccentric nuclei. As we discussed, if we do trio myogenic immunostains, desmin expression is typically diffuse and strong in the cytoplasm of all of the neoplastic cells of embryonal rhabdos. Immunostaining for myogenin and MyoD1 are usually focal or patchy in embryonal rhabdo, unlike alveolar rhabdos, which we discuss later and show a diffuse expression of these nuclear stains. Remember, the cytoplasmic staining is non-specific and should be ignored in MyoD1 and myogenin. Embryonal rhabdomyosarcomas cannot be confirmed with a single targeted molecular tool, so they should not be systematically tested for fusion, such as FOXO1 gene, which we will discuss later in this talk. Bothroid embryonal rhabdomyosarcoma is the famous variant of rhabdomyosarcomas. This tumor was described grossly way before the conventional embryonal rhabdomyosarcoma in the middle of 19th century. Because of the characteristic gross pathology, it was described sarcoma botryoidis, or a sarcoma of grape-like mass. It constitutes approximately 6% of all rhabdomyosarcomas, and this is the most common vaginal cancer in infants and young children. It can occur in epithelial-lined viscera, especially in vagina, that can protrude through vaginal introitus. It has an excellent prognosis after treating with surgery, chemotherapy, and radiation with a 90 to 95% cure rate. Both variants of rhabdomyosarcomas presents as an exophytic polypoid growth from underneath mucosal surface. Tumor has a variable cellularity with usually abundant loose myxoid stroma. Characteristic finding in this sarcoma, as shown at the right image, is the presence of a superficial zone of increased cellular density underneath the epithelial surface. This zone is termed the cambium layer. Anaplastic embryonal rhabdomyosarcoma is another morphologic variant, which is now a subtype of embryonal rhabdos in WHO book. They include 3 to 13% of embryonal rhabdomyosarcomas. It has scattered of clusters of malignant cells, which are markedly large, atypical, usually more than 3 times the background sarcomatous cells. Their nuclei are enlarged and hyperchromatic, and atypical mitotic figures are common. This subtype of embryonal rhabdomyosarcoma should not be confused with pleomorphic rhabdomyosarcoma, which is a well-described type of rhabdomyosarcoma that has diffusely polymorphic morphology, and we'll talk about shortly. This image shows scattered anaplastic cells with marked enlarged atypical cells, which are 3 times larger than background tumor cells. These cells have hyperchromatic bizarre nuclei, and the cell with multipolar mitotic figure is seen in the middle of the image. Embryonal rhabdomyosarcomas overall do not have terrible outcome, with an overall survival of 70% at 5 years at localized stage. But the prognosis is variable based on important risk factors, including age, with a better prognosis of children between 1 to 9 years of age compared to infants, adolescents, and adults. Tumor stage, like other tumors, we see that we advance stage, tumor outcome will get worse. Among variants, botryoid has the best prognosis versus the anaplastic with worse prognosis. In terms of the location of the tumor, orbital and testicular and the vital sites show a favorable outcome versus parameningeal and extremities embryonal rhabdomyosarcomas. As I said, overall, embryonal rhabdos do not have terrible outcomes and do significantly better than alveolar rhabdomyosarcomas. Talking of alveolar rhabdomyosarcomas, this is the second group of WHO classification of rhabdomyosarcomas. It was first described by Dr. Riopol in Montreal, approximately 60 years after the embryonal rhabdomyosarcoma's description. It is the second most common type of rhabdomyosarcomas, consisting 25% of all rhabdos. Alveolar rhabdos occur in slightly older population, predominantly in adolescents and young adults, with peak incidence among individuals between 10 to 25 years of age, and roughly equal incidence in male and female gender. They can occur in older patients, but rare in terms of location. The most common site of alveolar rhabdo is deep soft tissues of extremities, followed by head and neck, paraspinal, and perineal regions. Alveolar rhabdomyosarcomas are known and associated with recurrent FOXO1 fusions, previously known as FKHR gene, located on chromosome 13. 80 to 90% of alveolar rhabdos are associated with FOXO1 gene rearrangement. Of those FOXO1 fusions, 70 to 90% has a fusion with PAX3 gene located on chromosome 2, and 10 to 30% has fusion with PAX7 gene located on chromosome 1. Less common fusion gene variants include the fusion of PAX3 to FOXO1 or NQA1, Please also remember these less common fusions. We will get back to them later in this talk. Grossly alveolar rhabdos are soft, fleshy, and gray with variable amounts of fibrous tissue, and sometimes necrosis and hemorrhage can be seen. And they are usually deeply located, infiltrating surrounding tissue. Alveolar rhabdos are generally highly cellular. The classic morphologic pattern includes nests and sheets of primitive rounded cells, which are separated by prominent fibrous septa. And this pseudoalveolar pattern that is shown here is imparted by the central loss of cellular cohesion and loss of viability within the tumor nest. The solid morphology variant of alveolar rhabdomyosarcoma exists and composes of sheets of neoplastic cells. These cells have cytomorphological features of alveolar rhabdo with these primitive round cells. However, they lack septa or the cohesion. This solid morphology variant of alveolar rhabdo can be very challenging to differentiate from embryonal rhabdomyosarcomas or other small round blue cell tumors. That is where ancillary studies will absolutely help to diagnose these tumors. As far as the trio immunostains, cytoplasmic desmin expression is typically strong and diffuse, and the alveolar pattern can be sometimes highlighted as in this example. There is diffuse strong nuclear expression of myogenin and MyoD1. This diffuse level of positivity for myogenin and MyoD1 is rarely seen in embryonal rhabdos, as we discussed earlier, or in pleomorphic rhabdomyosarcomas. Again, remember that myogenin and MyoD1 are nuclear transcription factors, and any aberrant cytoplasmic staining should be disregarded. Immunohistochemical studies can be challenging with some serious diagnostic pitfalls. Dr. Bahrami et al. Evaluated 44 alveolar rhabdomyosarcomas for epithelial and neuroendocrine markers, and they found that these markers can show aberrant expression in some alveolar rhabdomyosarcomas. They found these markers can show some degrees of positivity in 30 to 40% of alveolar rhabdomyosarcomas, and we should be aware of them as a pitfall in diagnosis. Epithelial markers expression occur particularly in cyanonasal alveolar rhabdomyosarcoma. CD99, which is, we know, basically a non-specific marker, can also show patchy expression in some alveolar rhabdomyosarcomas. Importantly, molecular studies is essential for all newly diagnosed alveolar rhabdomyosarcomas and are routinely performed. The detection of PAX3-FOXO1 fusion or PAX7-FOXO1 fusion can be done by FISH, like this example, which shows dual color break-apart probes for the FOXO1 gene on chromosome 13, and split red and green signals, which shows an abnormal clone with a translocation involving FOXO1. Or this could be done by reverse transcriptase PCR and direct sequencing. As you can see on the right panel, practically the absence of one of the gene fusions suggests a diagnosis of embryonal rhabdomyosarcoma with a primitive phenotype. These were previously known as fusion-negative ARMS or mixed embryonal and alveolar rhabdomyosarcomas, which are not currently recommended in WHO classification of tumors. Alveolar rhabdomyosarcomas are fully malignant tumors, high grade, with significantly worse prognosis than embryonal rhabdos. The 5-year survival rate for alveolar rhabdos is only 54%. The intergroup rhabdomyosarcoma study grouping, or IRSG, staging is predictive of outcomes. The IRSG risk stratification is based on the stage, age, location, and fusion status of alveolar rhabdomyosarcomas. Importantly, the fusion-positive alveolar rhabdos do have worse prognosis than fusion negatives, and PAX3-FOXO1 fusion have an inferior outcome compared to PAX7-FOXO1 fusions in alveolar rhabdomyosarcomas. The third group is pleomorphic rhabdomyosarcomas. Pleomorphic rhabdomyosarcoma was described by Dr. Stout in 1946. These are high-grade sarcomas of adulthood with numerous pleomorphic rhabdomyoblasts. These tumors almost exclusively occur in adults older than 45 years of age, with a mean age of 72 years. Pleomorphic rhabdos occur more in males than females, and like alveolar rhabdomyosarcomas, this tumor commonly occur in deep soft tissue of lower extremity, particularly in thigh. Less common locations include chest and abdominal wall, upper extremities, and abdominal retroperitoneum, and head and neck region. Their pathogenesis is poorly known, with complex genotypes, and there is no consistent molecular abnormality. Like undifferentiated pleomorphic sarcomas, or UPS, pleomorphic rhabdos may show numerous copy number of alterations across genome, and TP53 gene is inactivated in this tumor. And as I said before, they are extremely rare in childhood. If they occur in pediatric population, it should raise suspicion for an underlying genetic disposition like Nephromy syndrome. Pleomorphic rhabdomyosarcomas are usually large tumors, more than 10 centimeter in diameter, and can be a circumscribed mass located in deep skeletal muscle or adipose tissue, as you can see here. Their cut surface is usually whitish or fleshy, often with extensive necrosis. Histologically, they have diffuse sheets of pleomorphic rhabdomyoblasts with large polygonal cells and pleomorphic nuclei and abundant eosinophilic cytoplasm is shown here. Unlike anaplastic subtype of embryonal rhabdomyosarcomas that we described before, these tumors have more diffuse pleomorphism, and essentially they can resemble any undifferentiated pleomorphic sarcomas. The tumor cells of pleomorphic rhabdomyosarcoma display diffuse, strong cytoplasmic expression of desmin. The intervening normal skeletal muscle fibers are also positive that you can see actually on the left panel. Myogenin and MyoD1 immunostains are usually strong, but they are patchy or focal. Pleomorphic rhabdos is a highly aggressive disease with early metastasis, commonly to the lungs. Their mortality rate is approximately 80%, with a median survival period of just 7.3 months, which is terrible. Superficial tumors show a favorable outcome. The last but not the least is the spindle cell / sclerosing rhabdomyosarcoma group. These tumors added to WHO classification in 2013 as a single entity, merging the spindle cell rhabdo with the sclerosing rhabdomyosarcomas. There are 3 recently added subtypes to WHO classification 2020 for this rhabdomyosarcoma group, with quite long names based on the gene abnormalities. Spindle cell rhabdomyosarcoma was first described by Dr. Cavazzana in 1992, and sclerosing rhabdomyosarcoma was first described by Dr. Fulp in 2002. These 2 entities were classified as a part of embryonal rhabdomyosarcoma previously, but the overlapping morphologic features seen in both the spindle cell and sclerosing rhabdomyosarcomas suggested the relationship between these 2 groups. And later, with the strongly supported overlapping molecular genetic features, it became more obvious that these 2 entities are very related. Consequently, the WHO classified them as a single class of rhabdomyosarcoma, as I said, in 2013, and this continues in 2020. This new group of rhabdomyosarcomas are rare and constitute only 3 to 10% of all rhabdomyosarcomas. They can occur in infants, children, and adults, and they occur in different sites in adults and children. In adult group, they occur in head and neck, followed by extremities, and in pediatric population, they are usually located in paratesticular region, followed by head and neck. Again, there are 3 subtypes in this group of rhabdomyosarcomas with characteristic genotype alterations. The first subtype shows different gene fusions involving VGLL2/SRF, TID1 and QA2 and CITED2 genes. The second subtype shows a somatic point mutation in MyoD gene, and the third and the recently described intraosseous spindle cell rhabdomyosarcoma shows either the EWSR1 or the FOS gene fused to the TFCP2 gene. The MICE1 and QA2 fusion has also been described. This subtyping shows that all rhabdomyosarcomas associated with the pure spindle cell phenotype should be tested for the presence of these genomic abnormalities, at least for presence of MyoD1 mutations and these fusions. Congenital infantile spindle cell rhabdomyosarcoma with VGLL2 and QA2 CITED2 rearrangements was first described by Dr. Allegio in 2016. This subtype of a spindle cell sclerosing rhabdomyosarcomas is almost exclusively occurs in infants or children younger than 5 years of age. These are low-grade rhabdomyosarcomas and have actually a favorable clinical course. Histologically, these rhabdomyosarcomas are organized in intersecting fascicles, as you can see in H&E, composed of cells with elongated monomorphic nuclei. Tumor cells express diffusely desmin, variable level of myogenin, and MyoD1 more consistently expressed than myogenin in these tumors. MyoD1 mutant spindle cell sclerosing rhabdomyosarcomas was first described by Dr. Zhuhei in the Netherlands in 2013. This subtype is probably the most well-recognized subtype of spindle cell sclerosing rhabdomyosarcomas, with 4 available series since then. They occur in a wide range of age, and 1/3 of them occur in head and neck region, followed by extremities and trunk. Unfortunately, they have a very poor outcome with 3-year survival rate of 36% and 4-year survival of only 18%. Histologically, they show spindle cells arranged in fascicles with a collagenous stroma. Tumor cells show nuclei without any polymorphism, and they express desmin, and as expected, MyoD1 is diffusely positive, while myogenin has been reported patchier in this subtype. For this subtype, the MyoD1 point mutation can be detected on direct sequencing. Intraosseous spindle cell rhabdomyosarcoma with TFCP2/NQA2 rearrangements was recently reported by Dr. Watson et al. In 2018 in France, and there are 2 clinical pathological series which have been published since 2018. These tumors have an unusual predilection for bones, particularly craniofacial bones with soft tissue invasion. They occur in a wide range of age groups. Interestingly, they can show positivity for cytokeratin or EMA and ALK. These are quite aggressive tumors with a median survival period of 8 months. Here is shown an intraosseous spindle cell with FOS TFSCP2 rearrangement. Reportedly, this tumor destroyed the cortex of the mandibular bone and extended into adjacent soft tissues. Histology of the tumor cells show they grow in long fascicles consisting of relatively monomorphic spindle cells with a moderate amount of eosinophilic cytoplasm and also area with epithelioid morphology. Desmin and MyoD1 highlighted the tumor cells. A strong expression of ALK was also present in this case, as we discussed already. Okay, so now that we have already discussed all the types and subtypes of rhabdomyosarcomas, I would like to talk about the mesenchymal malignancies with rhabdomyoblastic differentiation, but not classified as rhabdomyosarcomas. These tumors are malignant and are completely different entities than rhabdomyosarcomas. I found that we should be aware of these tumors and keep them in mind as a pitfall in diagnosis, because they can show rhabdomyoblastic differentiation both morphologically and immunohistochemically. The first tumor that I would like to talk about is Ectomers and Chymoma, with the caveat that this tumor is currently classified under the skeletal muscle tumors. They are very rare sarcomas, which were also known as gangliorhabdomyosarcomas, the term which is not recommended anymore by WHO. They usually occur in children younger than 4 years of age and are clinically aggressive tumors. These tumors have a multi-phenotypic differentiation, usually a combination of rhabdomyosarcomas, which usually resembles embryonal rhabdomyosarcoma, and a neuroectodermal component, including usually neuronal or Schwann cells. Rhabdomyosarcoma component is positive for myogenic markers, as expected, and neuroectodermal component can be positive for neuroendocrine marker and NSE, or S100 protein for Schwann cells. The other tumor, which is classified under peripheral nerve sheath tumors, is a malignant Triton tumor. Malignant Triton tumor is essentially a malignant peripheral nerve sheath tumor, or MPNST, with heterologous rhabdomyoblastic differentiation. These tumors occur in adults, usually older than 30 years of age, with neurofibromatosis type 1. Unfortunately, they have very poor outcome, worse than conventional MPNSTs. Mesenchymal chondrosarcomas are classified under chondrogenic tumors. It is a high-grade malignant biphasic mesenchymal tumors with a well-differentiated organized hyaline cartilage component with a characteristic K1-MK2 fusion in more than 90% of cases. They are aggressive tumors with 5-year survival rate of 60%. In 2018, Dr. Folk introduced 6 cases of these tumors with immunohistochemical rhabdomyoblastic differentiation in mesenchymal chondrosarcomas as a potential diagnostic pitfall. Aberrant skeletal muscle markers expression can be seen as shown in images in this case. Another interesting tumor which I want to talk about is a tumor of head and neck, which is the biphenotypic Cyanonasal Sarcoma, or BSNS, which is essentially a low-grade, locally invasive spindle cell sarcoma, occurs in cyanonasal tract of adults. They do have a characteristic recurrent fusion, most commonly PAX3 MAML3 in 60% of cases, but more interestingly, they can have PAX3 FOXO1 and PAX3 NQI1. These are the 2 less common fusions that I already talked about, and I said that, remember these, the same fusions that we discussed in alveolar rhabdomyosarcomas, and these tumors can show rhabdomyoblastic differentiation, interestingly. In 2019, Dr. Lolorer studied 41 cases of BSNS and studied the molecular spectrum and immunohistochemical profile. These tumors showed 100% positivity for S100 protein and the negative for dead negative actually for SOX10. They reported Desmond was positive in 66%, and MyoD1 was positive in 91%, but myogenin only showed positivity in 20% of these cases. We can also use PAX3 for these cases. PAX3 can be positive in some of these cases diffusely, and you can see over here. Sarcoma with EWSR1 PATS1 fusion is one of new tumor entities belonging to the family of round cell sarcoma with EWSR1 non-ETS fusions by WHO. This sarcoma usually occurs in deep soft tissue with predilection for the chest wall and abdomen. Interestingly, both EWSR1 and PATS1 genes are located on chromosome 22, just 2 megabases apart. The fusion involves a pericentric inversion. They have a fairly diverse histopathologic morphology, like a small round and or spindle cell with fibrous stroma. Co-expression of myogenic markers like desmin, myogenin, and MyoD1, and neurogenic markers like S100 are seen. These sarcomas have an aggressive clinical behavior and can metastasize and cause death. We already mentioned that patients with Dicer-1 syndrome had an increased risk of embryonal rhabdomyosarcoma in the uterine cervix or bladder. This is an autosomal dominant syndrome characterized by appearance of rare neoplasms, including pleuropulmonary blastoma, thyroid cancer, pediatric cyst nephroma, ovarian sertoli-lytic cell tumors, and embryonal rhabdomyosarcoma of the cervix, as I mentioned. In 2018, Kolshi et al. Studied 22 primary intracranial sarcomas and 2 uterine rhabdomyosarcomas, all which had actually Dicer-1 hotspot mutations. They found these tumors have rhabdomyosarcoma-like features, including presence of focal rhabdomyoblast differentiation and desmin expression with a scarce myogenin. MyoD1 was not evaluated in their study. They proposed another long term for these tumors, spindle cell sarcoma with rhabdomyosarcoma-like features, Dicer-1 mutant. Okay, let's see. Histiocyte-rich rhabdomyoblastic tumor is recently described skeletal muscle neoplasm of uncertain malignant potential, first described by Martinez et al. In 2019. They reported 10 cases of these tumors. They are usually circumscribed tumors located in deep soft tissue of lower extremities, trunk, and neck of young to middle-aged adults. They have a slow growth circumscribed with surrounding lymphoid aggregates and dense intratumoral histiocytic infiltrate, which can be highlighted by histiocytic markers like CD163. All cases showed diffuse desmin positivity and focal positivity for at least one skeletal muscle marker like myogenin or MyoD1. Their prognosis was good, and available information for follow-up showed no recurrence or metastases in these tumors. In summary, skeletal muscle tumors, including rhabdomyosarcomas, are highly heterogeneous. Rhabdomyosarcomas currently have been divided in distinct subtypes reflecting their morphological and phenotypical, clinical, and molecular features. The rhabdomyosarcoma into these is still an ongoing work, particularly based on molecular characterization, and the presence of rhabdomyoblastic differentiation in a tumor does not lead automatically to diagnose rhabdomyosarcomas. And these are my references. I believe I talked a little bit fast and quick, but at the end, I would like to acknowledge everyone. It has been my pleasure to work with and learning from every one of you during my training. Thank you for teaching me during my training and contributing to me to get my 2 consecutive fellowships, starting with bone soft tissue pathology this July, followed by a dermpath fellowship next year. My special thanks goes to Dr. Perry Merrigan for introducing this topic to present and for his help. I would like to thank Dr. Giublino for the projects that we worked together, and Dr. Khalifa for his teaching and mentorship, Dr. Clark and Dr. Snelver for their weekly great teaching sessions, and I appreciate all LMP faculties, PAs, and ancillary staffs for their teaching and contribution. I also would like to thank our residency program directors, Dr. Dolan and Dr. Johnson, and our residency program coordinator, Maggie. Again, thank you, Amy, for organizing this meeting. And the last but not the least, our fantastic residents and fellows, thank you guys. Okay, so
okay, questions, anyone? Good job, Pooria.
Thank you, Pooria. Thank you, Pooria. This is a very nice overview of the topic. It's a very complex topic, and you did a very good job. I like your take on the presence of just the simple presence of rhabdomyoblasts doesn't make it a rhabdomyosarcoma. And I was hoping you can tell us a little bit about some of the uterine leiomyosarcomas when they have occasional areas of rhabdomyoblasts, and whether this requires further studies, or you know how we do it. We look at them, they look rhabdomyoblastic, we do myogenin, and we say focal rhabdomyoblastic differentiation. Do you think we need to pursue it further to subclassify the rhabdomyosarcoma, or tell us more about that, please?
Yeah, sure. So rhabdomyosarcoma of the cervix exists as a dicer-1 syndrome, Dr. Khalifa. And interestingly, as you mentioned, I just talked about the mesenchymal tumors that can show rhabdomyoblastic tumors. I knew that this topic, people may ask about the other tumors, like the epithelial tumors, that can also show the rhabdomyoblastic tumors, even in ovary, like cerulolitic cells. Yeah. So I pulled this. Can you see that?
Yes.
Yeah, I pulled this from Dr. Weiss' soft tissue book, and this is kind of the other tumors, shows the other tumors which can show rhabdomyoblastic differentiation. As I said, I just talked about the mesenchymal tumors or the sarcomas with the rhabdomyoblastic features, which should be aware of as a pitfall. But yeah, definitely there are some other tumors like carcinosarcoma, which I know that's one of your favorite tumors, can show definitely the rhabdomyosarcoma features or rhabdomyoblastic differentiation. And of course, the dicer-1, which has that specific cervical rhabdos in them. And of course, the cerulolitic cell tumor and germ cell tumors are also the other tumors that can show them. They are not still in the classification of rhabdomyosarcomas, at least they are not yet. But I don't know what happens actually in the next classification.
Yeah, so they don't change our diagnosis basically from that table.
No.
Yeah, thank you.
Dr. Hirsch has a question for you, Pooria.
Yes, Dr. Hirsch.
Betsy, if you have a question?
I can barely hear Dr. Hershey. I think
Okay, I don't know if we're coming through.
Amy, I can have a question meanwhile. So thank you, Pooria. It was an excellent talk and very good coverage of different mutations. And you listed appropriately all the mutations with different entities. The one thing that actually we can actually all observe is a shift, a gradual shift in the last 10 to 15 years from using mutations just to diagnose or subclassify the different types of rhabdomyosarcoma into those with, that have actually a direct impact on prognosis, and especially on the discovering and characterization of targetable mutations in rhabdomyosarcomas. So the one that actually was very well studied was the PAX-FOXO1, of course, because it was associated, especially for pediatric population, with both alveolar and embryonal. But there are other mutations, and I was wondering if you came across any of those different types of mutation profiles that have been studied with direct impact for prognosis. The question is actually also important because there is also a shift in the culture and the way we actually diagnose these tumors. In immunohistochemistry, we know exactly what type of markers we can use, but it is much more important these days to actually look for those markers by immunohistochemistry that have a direct impact in management.
Yes. Yes, you mean like PAX3 stains or something like that?
Yes, but I was wondering about different mutations, like for example, specific mutations in MyoD1, if you came across any of those with direct impact for prognosis. There is a group of 5 gene expressions actually that are correlating very well with survival and prognosis, rhabdomyosarcomas. Other genes that have a direct impact on management and prognosis that we should test for these days are NCOA2, VGLL2, for example. Those also have a direct impact on prognosis. So if you came across any of the, this kind of, information, that would be very useful.
Yeah, so I don't know if there is any immunohistochemistry studies for them, but I know that there is a molecular and also fish study for them. I talked about actually the fourth group that is in WHO book. Let's just go over them again. So let me just show it to you here. Yeah, so probably I just talked about them a little bit fast here, but these tumors are already been described with these fusions, and as I said, they do have actually not a good prognosis, especially the MyoD1 mutant spindle cell sclerosing rhabdomyosarcoma with this MyoD1 point mutation. And as you mentioned, the other tumors with the VGLL2 and COA2 and CITED2 partners are also classified, which are present actually in the just the children group or the very early age group of children. So molecular study is not my field. Probably one of the people who are doing molecular cytogenetics can probably talk about this, but I'm pretty sure that we have some probes for doing this fish studies here.
Yeah, I think Dr. Nelson may actually, have some input on that. Another important topic actually to cover about rhabdomyosarcoma is their association with other syndromes, like Li-Fraumeni, neurofibromatosis backed with Whitman, for example. Those would be some of the major associations.
Yes, so they are associated with. I think I already talked about them. Probably it was in my early slides. They are associated usually with embryonal rhabdomyosarcomas. Yeah, that's a good point. So they have already been described and they are already there.
Yep.
Thank you. Thank you for your
Thank you.
Okay, Betsy?
I'm going to try again. Can you hear me?
Yes, we can hear you. Please.
Okay. Sorry about that. I had some audiovisual problems. So actually, this is a really a question that kind of piggybacks onto Emil's. We certainly have some fish probes, and we run them pretty often for the more common subtypes. But I think what's happening in rhabdo is very similar to what's happening in other solid tumors as well as hematologic tumors, where the number of mutations and the number of fusions are just increasing, you know, weekly, monthly. And it becomes really impossible to keep up with that by fish or by specific targeted assays. And I think what I'm wondering is, and kind of following what's going on with, let's say, a company like Foundation Medicine or some of the large national and international trials, is whether or not we should be getting RNA from these tumors and actually storing that. It needs to, you know, obviously it has a short half-life once you get it. And should we be looking at something like RNA-seq to basically identify more of these fusions than we would going one by one, which is going to be impossible for some of these rarer subtypes.
Hi, Betsy. It's Andy.
Hi, Andy.
I'm getting the impression from you and Emil that I'm supposed to answer this question. The answer is yes.
Yes.
And then the answer is, thank God Pari's here. So Pari's been working with me, and you know, he's really is just an amazing content expert. We right now run RNA fusion analyses for things that are largely targetable. So ALK, ROS1, RET, NTRK. You know, so most of the RNA-based fusion analysis, and you know, it's RNA-seq, but to be clear for everybody on the line, it's targeted RNA-seq, so it's not, you know, whole transcriptome. And we are going to change over to a different form of targeted RNA-seq, a different technology called anchored multiplex PCR. It comes from a company called Archer. I've been working with Pari, I've been working with Fachin, I've been working with Liam, I've been working with Mark to make sure that we've got most of the fusions covered that are diagnostic within sarcomas, pediatric, CNS covered on this new panel that'll have about 108 different gene targets. So Pooria, thanks for having this slide up. So it targets NCOA2, it targets VGLL2, it of course targets EWSR1, it targets FUS. The nice thing about this form of RNA-seq technology, targeted RNA-seq technology, is it is agnostic to tumor gene fusion partners. So in other words, if it captures NCOA2, it will capture SRF fused to NCOA2, it'll capture TAD1 fused to NCOA2, et cetera, et cetera. So it's a very cool technology. It's been around for a while. It works reasonably well. You know, I think the one thing, Betsy, that I think you might have been kind of hinting at, though, is that the problem with broad-based NGS is that, of course, you don't have performance characteristics for every single fusion. Whereas, you know, and this is obviously why it's onerous to target, to bring up fish for every single fusion, but, you know, you are looking for something very specific with a fish probe generally. Sometimes, obviously, with break-apart probes, that's not necessarily the case, but you know, there's probably some decrement the broader of a fusion panel you go, and that is certainly the case when you use full transcriptome RNA-seq and use different types of in silico, or computational algorithms to identify gene fusions. With that being said, I love to pick on Foundation One at every single opportunity. Foundation's heme panel does do paired RNA analysis in a targeted fashion for fusions. RNA's solid tumor panel does not, which is why if you have a sarcoma, you want to use Foundation's heme panel, not their solid tumor panel. They will not capture any of these. And Caris, they attempt to do whole transcriptome RNA-seq both for gene expression as well as for fusion detection. But as I just said, the broader you go with your RNA-seq, the less sensitive your individual specific high-value diagnostic targets will be. So it is, as with all things in molecular, a consistent balancing act of how big do you want to go, how much money does that cost. Caris, cuts through, I don't know, probably 90% of the block. They require 25 or more sections in order to do their analyses. So it all gets quite difficult. With that being said, everything that I was just discussing can be done on RNA that is taken from FFPE. So we don't necessarily need to move to, snap freezing all of these tumors per se. Most of the RNA analyses that are done for focus diagnostics are still compatible with FFPE.
Pooria, that was an excellent presentation. And Betsy, to answer your other question, for the past 2-3 years, yes, most of our Rhabdomyosarcoma cases, and in fact, several other sarcoma cases have been having comprehensive genome profiling testing ordered. So we do have an enormous amount of data on these cases. And as Andy was mentioning, going into the future as well, we will have our home panel here, the Archer panel that Andy's been working so fantastically on, and we are very thankful to him for he's about to bring that on board. So that would be a fantastic advancement for us, both in terms of timeliness and the availability of these tests. So there'll be more encouragement for people to order them. So yes, we are getting there, and we are getting there pretty fast. And going back to Dr. Khalifa's question, so how do you actually define rhabdomyosarcoma? So I kind of think of it in a spectrum. So on one end of the spectrum, you have tumors that have clearly rhabdomyoblastic differentiation, are positive for Desmond myogenin and MyoD1. The clinical scenario fits, so you call them rhabdomyosarcoma, and then they are fusion positive for FOXO1. Then you can look for the partner, PAX3, PAX7 for the prognostic impact. And then on the other end of the spectrum, you have certain tumors that show clearly other types of differentiation, like the mesenchymal chondrosarcoma I was mentioning, and the whole list of tumors that Pooria showed. Teratomas can have rhabdomyoblastic differentiation. So that we just leave them as rhabdomyoblastic differentiation because we know clearly there's another diagnosis there, and there's only a small component that's showing some rhabdoid kind of differentiation. But the thing is, in the middle of these two extreme ends, we have a huge gray zone that we are discovering more and more recently. And as you also mentioned, that almost every month we get a new translocation that is associated with rhabdomyoblastic differentiation. In fact, even like last week, I had a pleomorphic undifferentiated sarcoma that happened to be positive for Desmond myogenin, and it had a new mutation. There was a fusion of the red gene, and the literature does indeed mention, there was a paper published, I think in 2020, but by Christina Antonescu's group, who in fact described this very, very same fusion that was the latest kid on the block for rhabdomyosarcoma. So I think going forward, what's going to happen is basically we have rhabdomyoblastic differentiation that's substantial enough and cannot be categorized into other tumor types. And then you do your genome profiling studies, and you identify the mutation, and you can put into the groups that are already known or create a new group for them. And the key is, as Emil mentioned, you've got to prognosticate. You have to see whether these have any prognostic value. And many of them do have. And that's the whole point of the exercise, right? Trying to look at the mutation. So, for example, the BGLL2 mutation, the spindle cell rhabdos in kids, they behave very well. But there are other spindle cell rhabdos that do not have BGLL, but have the mutations like TCFP2, which in fact behave much worse, but may look morphologically very similar with the same immunohistochemical markers. So I think we are getting into a very, very good space. It may be a little bit confusing as of now, but it's going to be solidified down the line into a very impactful classification.
One last very quick question for Pooria. Pooria, number one, fantastic presentation and wonderful acknowledgement of the faculty, particularly Dr. Murugan. And the quick question is, would you say, though, that with all of this advancement and the burgeoning knowledge about molecular translocations and immunohistochemical probes and et cetera, wouldn't you say, based on your presentation, that we should still assume that it starts with someone who has the good training and experience to recognize a specific histology under the microscope and proceed forward with the workup?
Yeah, thank you, Dr. Dayton, for a nice comment and great question. Definitely. So everything starts with histology. So the first step, as I mentioned, is to just identify this as a sarcoma. And as Dr. Murugan mentioned, we can start from there that we are dealing with a sarcomatous tumor. But to be honest with you, some of these tumors are very poorly differentiated sometimes, especially if you are just getting a needle core biopsy, which is really the case in biopsies. It's sometimes impossible to differentiate it from any other small round blue tumor cell. So we have to do some immunostains at some point to make sure that this has a skeletal muscle or any other tissue differentiation.
Thank you.
Thank you.
All right, you guys. Thank you for a wonderful program this morning. Good job, Pooria. And we will see you all next week. Take care.